I appreciate everyone's talks. I think that this session really did create the foundation for the rest of the summit. I would like to go ahead and open it up for discussion or questions. If anybody in the audience has a particular question, please raise your hand. And yes. So I'm just going to repeat the question for the people who are listening on live stream. The question really is on H. pylori prevalence by ethnicity and race, and where some of the assumptions were made, particularly for the cost effectiveness model. So Shailja, you want to start tackling? And I will say that we have future sessions that are specific to H. pylori, and so I think that might be better answered in the other sessions. But Shailja, why don't you go ahead and tackle your specific question?
Sure. Yeah. Thank you for those questions. They're excellent. Unfortunately, in the U.S., with respect to H. pylori prevalence and the racial and ethnic distributions, especially for Asian Americans, we don't have data for Asian Americans, strong data. There's some single center studies. What we rely on really is, as you're probably aware, there's a large systematic review and meta-analysis published in gastroenterology, maybe 2017, 2018, that looked at the worldwide prevalence of H. pylori. And even among the Asian American countries, where we do see still these very striking differences in gastric cancer incidence. So for example, Filipino Americans actually have a much lower, and Filipinos have a much lower risk of gastric cancer compared to Korean Americans, Japanese Americans, Chinese Americans, but pretty similar H. pylori prevalence rates, and sometimes even higher, especially with the focused eradication campaigns in Japan and Korea, that those prevalence rates of H. pylori are decreasing rapidly. So there's certainly other environmental risk factors, genetic factors, and those interactions in addition to H. pylori. And there's most likely strain-related aspects as well that play into that, so a lot of different factors. With respect to the inputs that we used for the models, it really was based on, so these models were, like I showed, the sensitivity analyses of the factors that really play into what influences the model most. From the cost standpoint, it really was early detection and preventing advanced stage disease, because the costs, especially in the United States, of chemotherapy and advanced care and not really achieving an actual cure was the biggest cost implication there. So early detection is key for this cancer. And so other things that fell into that were like intestinal metaplasia and the rates of progression, which we just took from the literature.
Chin. So yeah. Again, to repeat, Shailja, why don't you go and repeat the question? For
Sure. Yeah, and it was something that we were actually surprised at too. So the question was, we found that all Asian Americans, the 7 most common groups in the United States that we modeled, for all those groups, it was cost effective for the screening strategy of endoscopy at the time of colonoscopy, with surveillance if intestinal metaplasia was diagnosed. And in terms of South Asians and even Filipino Americans, that their rates of stomach cancer sometimes are slightly higher than non-Hispanic whites, and that really was the key. When we look back at the model, the comparison group is the no screening strategy. So we're not really comparing against another group per se. So we're looking at each group individually, and it was based on the incidence data of actual non-cardiac gastric adenocarcinoma that still influenced that model, since those rates are still about 1.8 to 2-fold higher than non-Hispanic whites. So that's why it still was a cost-effective thing. But you could see that it was less cost-effective than Asian Americans as an aggregate group.
Dr. Shah, can I ask a question?
Yeah.
So the next step in your cost-effectiveness study would be to add or evaluate the compounding factors like smoking and maybe sort of economic or insurance. About like 6 or 7 years ago, we did a very small pilot study in New Jersey of uninsured Korean Americans, and we screened, it was sponsored by a grant from a hospital that treated a lot of Korean Americans. So it was uninsured Korean American men were asked if they would be willing to undergo screening endoscopy, and we took their smoking history, their marital status, and H. pylori status, and there were some compounding, like sort of increased risk. So if you were a smoker, if you had a history of H. pylori, you were more likely to have intestinal metaplasia. And out of the 99 people screened, actually only 4 people had normal mucosa. Everyone had sort of an abnormal, but those were some of the risk factors. And it would be nice to see prospectively or in a much larger cohort if that would be cost effective in adding on those risks.
Yeah, no, and I completely agree. And we would imagine that it would, that any additional risk factors, because our intent with this first model was really just to establish based on the simplest thing of race and ethnicity, could this be cost effective? And really hinging on that early detection, and we have treatment now with ESD and resection if we diagnose those. So then our next step really would be looking at these factors, because with the AGA's technical review that came out, that we did look at risk factors that are associated with intestinal metaplasia and progression, actual progression. So those can be built into the model. The thing there is that we don't have, that the technical review didn't identify any data stratified by race and ethnicity. So it really, which is okay, because those factors still, yeah. So things like smoking, family history, the extent of intestinal metaplasia, histologic subtype, that those can all be built into the model.
We have time for one more question.
Thank you. So in thinking about CDH1 mutation, I congratulate you on what you showed us about the improvements in the surgical techniques that are reducing the morbidity of the surgery, but that doesn't affect, the life without a stomach. But my question is, it's my understanding that the penetrance of CDH1 mutation for getting gastric cancer is not 100%. It's been estimated between 30 and 50%. So I'm wondering whether really doing endoscopic screening is sufficient, or whether it's just an individualized discussion with patients, or if you see a very dominant family history for a particular individual where multiple relatives had gastric cancer. How I don't really think I understand exactly what we should be doing.
So I'm going to give you a very 101, because I don't understand it very well either, but there are people in the audience that may be able to help you. So my understanding of the CDH1 mutation is that there are familial, so the hereditary diffuse gastric cancer, those that come in families that are complete mutations, actually their risk of getting gastric cancer is almost 100% at some age. However, there are variants of the mutation which penetrance is not 100%. For example, there's now, one of our geneticists published a paper a couple years ago about how many variants there are and what they really mean. It's very difficult to know. We were just discussing the fact that CDH1 mutation is actually on a panel now for lobular breast cancer patients and all breast cancer patients. So I see a lot of older patients, not 20s and 30s, in their 50s and 60s, who have a variant of not 100% penetrance. So they have a risk assessment at what age, as older they get, about 60 to 80, and it could be as low as 30 or unknown. So it's not 100% for some, but it is 100% for some with the hereditary diffuse gastric cancer familial syndrome. And those are different sort of approaches that we need to take in counseling. But there is, Dr. Idos, you want to add anything to that as a GI geneticist? Help. This is a telephone help.
Phone a friend.
Yeah, call a friend.
So thank you. And I have a great friend and mentor here, Elena Stoffel, who could also add to this. So if we're going to bring everyone in, but I think the easy answer to that is the data is evolving. I don't think we had tested for CDH1 on such a large basis that we're starting to find out that there are certain variants, whether they're at a splice site or if they're at a truncating mutation, what the estimated penetrance of gastric cancer diffuse gastric cancer are in these patients. So it's evolving, but I think, Elena, if you want to.
We're giving Sheila a workout here. You got your Apple Watch on?
Thank you. I think just to add to that, I think it's actually really complicated because even in families, there can be variability in penetrance even with the same mutation in the family. So for instance, there are families where you see some people develop signet ring cells at 14, whereas their mother had a gastrectomy that had no signet ring cells at all. So I think that's where the uncertainty comes. The historical data suggests the lifetime risk for gastric cancer was 80% or higher. We know it's probably not that high, but there is tremendous variability even from family member to family member in some of these families that we're still trying to figure out what's affecting it.
Okay, thank you, and more discussion tomorrow, so please attend the research session tomorrow. So with that, we'll close this session. Let's take a 20-minute break and reconvene here at 10:40 for the next session, which I think will be fascinating. Is basically the Asian experience. And so with that, thank you to all the panelists, and we'll see you in 20 minutes.